Aloramitis. I am known as the Director of Joy. I'm also the Workforce Lead at the Cheshire Merseyside Training Hub, and we are all about attracting, growing, and retaining our workforce in primary care in one of the most complex and biggest ICBs in England. So we're going to start recording now for the first 10 minutes, and then if you've got any questions, please put them in the chat. We've got Kerry today that's going to be helping us with those, and it'll give us a bit of space to actually talk without that pressure of feeling like we're being recorded. Today, we are so thrilled to welcome Amy Thompson, who is a high street optometrist and an owner of an independent practice in Congleton, Cheshire. She's qualified in 2006 and later completed a master's in clinical optometry. So much learning, bringing nearly 20 years, that doesn't look right, of experience in practice. And Amy has also served on the Cheshire Local Optical Committee for about 15 years, supporting the development of enhanced optometry services. So hi Amy, welcome so much to 10 Talks. So tell me, what could a typical eye problem look like, and what, to a patient, why would they come to the high street?
Yeah, I think this has changed loads over my years in practice. It used to be that we'd basically clock up eye test all day long with a sprinkling of diabetic retinopathy screenings in there. But I think Bob's talk, if anyone saw it a couple of weeks ago, he showed that the enhanced service list that is available at high street optometry is quite vast now, almost to the extent that every eye-related issue can be dealt with first at high street practice. Qs and MECs, so that's the sort of minor eye condition services. They present us with the most acute cases that people come in and problems. You can either self-present, refer yourself here, go via the GP with or without actually seeing the GP. The receptionists can direct you to the service, or again via the pharmacy. In that service, I think optometry, we tend to see loads of dry eye cases, styes, and things like that. They are really easy to be managed in practice. Heat treatment with eye masks and things like that, a few drops and gels, really easy. Come in and we can get that sorted. We can also do follow-up phone calls and take on the ongoing care. And that means that patients are seen in practice. You don't have to be going to GPs, different people, pharmacists. We can keep that all, as I say, in your local optometric high street opticians. Next one would be gunky eyes. I'm sure we've all had a bit of green gunk come out of our eyes every now and again. Yum, yum. Again, that differentiation between what's needs to be treated and what needs to go to the hospital. Sit down behind me, you need one of those. Every high street opticians has one, and that means that we can differentiate between bacterial, allergic, viral, the most common causes, and also give you the specific treatment needed for those. We can either do that by over-the-counter treatments, we can send written orders to your pharmacist or your GP, or there's an increasing number of independent prescribing opticians, and they've done extra training, really intense extra training, to be able to prescribe the drugs needed to treat those really common eye complaints. So again, keeping it local, keeping it in practice with maybe a bit of co-management for prescribing, but keeping you out of secondary care. Black spots, again, another one that we see week in, week out in practice. Is it a floater or is it retinal detachment? I think plagues us all when we see eyes. Again, the only way to see it is with a slit lamp. Have a really good look. Optometrists are trained to look at retinas all day long. That's what we do. If it's just a floater, quite minor, most of them are, we can reassure patients, putting their minds at ease as well. If it is a detachment, we can get you straight to the clinics that you need to get the treatment for that. So again, missing out on A&E, sitting there waiting in A&E, on call optometrists, ophthalmologists as well, coming to see you. The patients get where they need to be in the shortest number of steps with the less wasted appointments and wasted time for everyone. So yeah, basically every eye related issue start with your high street opticians, and we'll either signpost you or see you and manage it all in practice. But yeah, that's the basic message.
It's such a different habit to break, is a difficult habit to break, isn't it? Thinking that you have to go to, a certain place if it's an emergency, but even just that reassurance to be seen is so important, especially if you're concerned about your health. It can be really debilitating for the rest of your social aspects of your life, can't it? You're not unsure about what's going to happen. To be seen so quickly by someone who can prescribe or refer, like you say, just all in that one place is so convenient. So
Yeah.
considering that you're in the middle of the high street, in the middle of these communities, how do you see the work of the integrated neighbourhood teams? We hear this a lot, this INT becoming more and more prolific. How is that going to help bring optometrists like yourself to this big table of community working?
Yeah, definitely. And I think the INTs can really be almost the conduit to bring optometry to that primary care table. And once we're there and we're sitting there, we can then showcase the fact that we have the capacity, the expertise, and the capabilities all sitting here waiting to be used and waiting, for patients and the wider NHS services to feel the benefit. Optometry fits really well into sort of NHS policies for delivering that local care. We can harness, all the expertise that we've already got in practice. We're all qualified up to a really high level. We've got loads of equipment, slit lamps, scanning machines, field machines. We've got that all there. And, we can use that to get people where they need to be as quickly as possible. And that reduces pressures on the GPs and secondary care as well. We reach quite vulnerable patients too. We have services for the learning disability population. We have pathways in place. In big major cities, we also have homeless, eye care for the homeless, charities up and running. So basically, once we're at that table, we can start showing what we can do for local services, but also every aspect of the population and the community.
As I'm hearing you speak, I already know of a service over in Sefton that again has created a homelessness service, particularly for health checks. You could see a cracking collaboration between you both there. It's setting up these, sort of like pop-up eye clinics and things like that. It's really exciting, especially because we know that those services sometimes need to go to those communities. Yeah, that's really interesting.
That's it. Yeah.
Could you give me an example of good practice between optometry and another service?
Yeah, we have in Cheshire, one of our local hospitals, so Leighton Hospital, Mid Cheshire Hospital, they, for the last few years, have developed a glaucoma shared care service. So patients who are already in the hospital who have either been diagnosed with glaucoma and have been managed really successfully and they're now really nice and stable, or if they have high pressures but no other sort of risk of it developing into anything else, they can then be referred out on a shared care pathway to optometry practices. We basically do the data collection. So instead of going to the hospital, you have your fields, your scans, your pressures, and have basically a data collection of all the information that we need to make sure that they're nice and stable. The primary eye care services is sort of the management service that then take on the care of that patient. And once we've seen them, if they're nice and stable, we can keep them in the system, which frees up appointments at the hospital for those patients who need it or have, need the sort of changes to their glaucoma treatment. If any of the patients we find are becoming unstable, they can again be sent back to those services. So it frees up hospital capacity for the patients who need it most, reduces waiting lists, the patients get a bit more local choice of where to go with appointment times and things like that. And it also, from practice point of view, you might get a few new patients in or, strengthen the links with our current practices. So I think that service, that glaucoma shared care ocular hypertension scheme, is really a win-win service.
Yeah, absolutely. And as you say, it's just totally reducing the pressure on areas that are already massively under pressure and
That's
giving
it.
it that critical care and unpredictable care to those that need it. Can you
Yeah.
believe that we've been talking for 10 minutes
I
already?
know.
So it's great. No, we're gonna stop the recording there. That was amazing. And we're gonna throw it out to